Hi, everybody. Hope you're doing okay. And we're going to start a new topic. The new topic is uh, understanding the nature of sexual dysfunction and disorders and how we address that in ways both biological and therapeutically in the counseling setting. Okay? So this is a complicated subject, so it's important that you read the PowerPoint. All right. In addition to the text, I might quickly add. So why is this important? Well, I think it should be obvious to you, yes, that in order to have a fully functioning life, if we're in a relationship, we have to have adequate sexual functioning because sex actually reflects and facilitates both intimacy and connection with our partners and with ourselves in that shared co-created phenomenon we call sexuality. And poor sexual functioning really has a dramatic effect, can have a dramatic effect on self-esteem and the quality of the relationship. And if there are issues in the relationship that are not functioning well, then the addition of sexual problems can make things a lot worse. So keep that in mind, yes? So a few definitions just to keep in mind and understand, okay? So the first thing is the phrase sexual dysfunction. That means that there's some thing not going well. There's some impairment or difficulty that's affecting sexual functioning or in some ways causing discomfort, emotionally or physically, okay? That's not the same as a disorder. Any disorder, in this case sexual disorders, are diagnosable problems. So they have a list of symptoms, a duration, and these things are invariably connected to distress and interpersonal difficulty. So these are their list of symptoms. So these are the things that are contained, actually, the disorders within the DSM, the Diagnostic and Statistical Manual of Mental Disorders. This version is version 5, May 2013. Okay? So now, there has been recently a greater emphasis on the biology of sexual dysfunction and sexual disorders. And in fact, many people, particularly, of course, in the medical community, has really medicalized this. And it's really important that you understand the interplay between emotional factors and physical factors. Sometimes it's very difficult to tell which is causing what. That's part of the artwork and the sleuthy nature of doing sex therapy. Now, there's a few other definitions you need to know. You can have a lifelong dysfunction. Something may not be going well your whole life. We sometimes call that primary. Or we could call something acquired, sometimes also known as secondary, where you didn't have it at one point, but now you do. We can also have something called situational dysfunction. That's where the dysfunction occurs with certain situations or certain people, but not everywhere with everyone. And then we could have a generalized dysfunction where things occur with all partners and contexts and settings, okay? All right. So remember, dysfunction means things aren't going well. Disorder refers to a specific group of symptoms, severity, and duration. Okay. I am not going to be able to talk about all the dysfunctions, but I want to talk about two in particular, one for males and one for females. But there's a list of more than just those. There's a bunch more. We have things like in males, delayed ejaculation, retrograde ejaculation, erectile dysfunction or disorder, female orgasmic disorder, female sexual interest arousal disorder, genitopelvic pain penetration disorder, male hypoactive sexual desire disorder, premature early ejaculation, sometimes called early, I like to call it early ejaculation, substance and medication-induced sexual dysfunction, and others. And so this list is actually a long one. Yeah. All right. What you find is that some dysfunctions occur earlier in life. So For example, in females, the inability to achieve orgasm is more common in younger women than in older women. Uh, in males, it's more common in older males than in younger males. Things like that. And you'll see lots and lots of data on this, which is interesting in the conceptualization of disorders. But when you're working with a client or clients, none of that really makes any difference because you're working with someone who's in front of you. Yes? All right. What are some of the factors that contribute to the development of sexual problems, whether they be dysfunctions or disorders? Well, one is being raised in a very restrictive, uncommunicative family, not having sexual education in any form that's substantial. Also coming from enmeshed or even disengaged families. Enmeshed meaning everybody's in each other's, there's no real separateness. Disengagement is too far apart. Having traumatic sexual experiences, particularly when they are younger. The younger you are, the more potential there is for problems associated with that in the sexual arena as you get older. Highly dysfunctional relationships, absolutely. And then the presence of psychological disorders like depression. Okay? Now, so there are, in addition to that, all sorts of medical conditions that can contribute to things. In terms of females, perimenopause or postmenopause. That peri means near. Pregnancy, postnatal period of time. Multiple sclerosis, chemotherapy, genital mutilation, gynecological cancer, spinal cord injuries. Just a slew of things that have to be eliminated as the cause when you start working with someone. Now, for males, there's also a big list. Genital surgeries, prostate cancer, prostatectomies where the prostate is removed. All sorts of things can interfere with sexual functioning. Now, one thing I want to point out as being critical to understand is that psychological issues, things like depression or bipolar disorder, anxiety disorders, okay, those sorts of things, psychological issues, can either cause or be caused by sexual dysfunction. Yeah, absolutely. So sexual or emotional abuse, relationship issues, stress. If someone's under, whether they're male or female, it matters not. But since women lead basically more stressful lives than men, you do understand that, yes? Okay. That stress alone can cause a disinterest. Not getting enough sleep, disinterest, or lack of energy. Just, we have to have some basics on board. We have to have enough energy. We have to be physically not in pain to any significant degree. We have to feel like our mind is not taken off of horrific things all the time that have to be done, or things from the past that are not in the right place yet within us. So this is all a bunch of stuff that contributes to problems, okay? So the use of drugs, prescribed or otherwise, blood pressure medication, antidepressants of various kinds can subdue libido or can subdue response. Antipsychotics, all sorts of things. As men age, the less loss of testosterone can get in the way. A male who is 50 has about 75% less testosterone than a 25-year-old. Yeah, okay, absolutely. So we have to keep those things in mind. We have to eliminate those things as being potential causes. So if a guy comes into your office and talks to you about how they really feel awful that they, in their relationship, can't achieve and maintain an erection, and he's 55, there may be a loss of testosterone element involved. It may not be the only cause, but we have to look at that. And so we would want him to get a check of how much testosterone he has. And if he's got some testosterone that's circulating in his body as measured by serum testosterone level check, then we could say, okay, it's not just that. It's not primarily that. What else is happening, okay? All right. So when we think about what we want to do, the first thing we got to do is decide what's causing what. And this is a very daunting issue. Very daunting issue. The one thing I want to mention in particular is diabetes, because it's become an epidemic. Pardon the use of the word these days, but it's become an epidemic. You know, the type 2 diabetes, which accounts for 95% of all types. The other is type 1 of diabetes. And this, if it's not well controlled, or it's not known that you don't know you have it, you therefore can't control it well, over time causes nerve death in the form of what's called diabetic neuropathy. It can affect lots of things, usually lower extremities first, but it can also hit any part of the body. And one of the parts that it can hit are the genitals. So both males and females can experience an inability for females lubricate or even achieve orgasm, and in males the inability to achieve an erection. Yeah. So this is an issue we have to deal with. All right. So what we see when we treat things is the idea in our brains as clinicians is we have to go through a process of really doing a good job of evaluating what's what. So when I take histories of people who have sexual problems, I give them a lot of paperwork to fill out. There's about 21 pages of questions and blanks to fill out that I have to go over. And in fact, I use 3 or more sessions of evaluation before I can really know where we're going to start. The next thing is, what's the first thing we're going to do? And the first thing you're going to do is the thing that's probably going to give you the biggest bang for the buck. And what will that be? Okay, so if you're working with couples, the first thing you might want to do is, how about let's start slow, and can the two of you go on a date Friday night and just, let's not talk about problems, let's not deal with all of this to start with. I'm still working on what's causing what with you all. So let's carve out a couple hours, 3 hours that you can have dinner and be together. And just don't worry about whether you're going to have sex or not. Just be together for a while. And that's a neat. But what I'm thinking in the back of my mind is there are steps. There's a whole protocol for dealing with each of these different potential problems and causes. And it gets complicated, and I think you'll see that when you look at the PowerPoint, yes? From medications to lifestyle changes to even, in some cases, particularly for males, surgeries, where they get flexible prosthesis components in their penis, inflatable devices in the penis, and pumps within the scrotum, which are very drastic measures, but maybe all they have. So there's all different levels of ways to intervene, and generally people are less hopeful than the possibilities that there are that actually exist that you can help them with. Okay, so what you want to do is form a relationship with people in a way that is very welcoming and not dire and dreadful. So people with sexual problems are very anxious and they're very embarrassed, and you need to respect that and understand that, yes? So when you're working with people who have sexual problems, you need to honor that and start slow, okay? I talk about some of the rarer disorders and dysfunctions, things like persistent genital arousal disorder and sexsomnia and coital cephalagia and clitoromegaly and things like that, a micropenis and so forth, seminal plasma hypersensitivity. You might want to look at those. I included these so you get a sense of some of the rarer things that we might deal with. Okay, look for the discussion question and you'll have a week to do that one. Take care, everybody. Stay safe.